Good morning, everybody. This is Kylie Hillner with Centralized Training at UT Health Science Center. We are happy you could join us for the first of 3 trauma-focused CBT webinars as part of the larger HHSC CMHTA webinar series. I'm happy to introduce Dr. Susana Rivera, who will be discussing TF-CBT and complex trauma today. Before I hand it over to her, there's just a few things I want to remind you of. That everyone is muted on the webinar, so the way to communicate is through the questions box on your control panel. So if you have questions that come up throughout the webinar, please type those into the box. We're going to have a little question answer time at the end of the webinar, so go ahead and type those in there as they come up. And if you have, comments or anything like that as well, that's where that will go. Don't forget, you can listen to the webinar either through your phone or through your computer speakers. It's easier, or it's better to just pick one of them so you don't hear that kind of feedback loop there. The slides for today's webinar are available under your handout section of the control panel, so you can look at them over there. We are also recording the webinar, so the link to the recording as well as the slides will be sent out to everyone later this afternoon. So without any further ado, please welcome Dr. Rivera.
Thank you. I am really excited to be doing this. I welcome any opportunity to speak about TF-CBT, and as was already mentioned, there will be a question and answer portion at the end. If there are too many questions to get to, I have already been informed that there will be a way to get those questions to me after our webinar ends, and I will be responding to any questions that I do not get to during our hour together. We have quite a bit to cover in an hour, and I will, of course, be respectful of everybody's time and make sure that we wrap up when we are supposed to, especially because for many of our listeners, we will be wrapping up right at about lunchtime, and I know people will be ready for a break. But thank you, everybody, again, for being on. I am Dr. Susana Rivera. Everybody knows me as Susie, which is most familiar and comfortable for me. And I am a nationally certified TF-CBT trainer. Complex trauma is one of those topics that comes up really, really frequently because this is what we tend to see in a lot of our children that we are working with. And if you will just bear with me for 1 second, my slides do not seem to be advancing. There we go. All right. So when we refer to complex trauma, again, this is something that most of the children that we are going to be working with will be experiencing. It is quite unusual for us to see a child who has only one isolated, single traumatic event that they have experienced. In my experience, when I've seen those isolated incidents, it's typically been grief cases. So these will be children who have never experienced any type of traumatic event, and then suddenly they lose somebody unexpectedly, they lose somebody very violently, and so that is the only thing that we are dealing with. But most of the children that we work with, they have experienced an average of 4 different trauma types. And this is something that may not be readily known to us when we get those referrals. I've mentioned during my introductory TF-CBT trainings that oftentimes children are referred because of behavioral issues, or when there is an identifiable trauma, we only hear about one, which is the most distressing or the one that is worrying caregivers the most. But once we really do a thorough trauma assessment, it is not unusual for us to identify multiple traumas. So when we speak about complex trauma, what we are referring to is the type of trauma exposure. And these are typically interpersonal traumas that children are experiencing. The impact that the trauma history has on both their short and long-term functioning. When we refer to complex trauma, we're typically talking about traumas that have begun at a very early age and have just been ongoing. For many of these children, when we work on trauma narratives, we typically will ask children about what life was like before trauma. But when we're working with complex trauma cases, for most of these children, there is no such thing as life before trauma, because for as long as they can remember, for as long as they have memories of what they've experienced, it has been one traumatic event after another. So we're looking at things like physical abuse and sexual abuse, neglect, being exposed to family violence, domestic violence, human trafficking. That's not something that is reported a lot, but it is something that our children are experiencing. And so these are the types of traumas that children are going to be experiencing just in an ongoing manner. This is not something that is typically going to happen once and not happen again. So when we have that ongoing trauma exposure from a young age, it is affecting their ability to function both in the short term and in the long term. This is what we're referring to when we're speaking about complex trauma issues. Excuse me. And one of the reasons that complex trauma is so toxic is because as children develop, as they develop new skills, they are building on the skills that they have already acquired, that they have already mastered before they move on to something else. So as an example, when you have a child who runs, the child first, before he could run, he had to learn to hold his head up. The child had to learn how to roll over, how to scooch himself up on his hands and knees, how to crawl, how to pull himself up, how to toddle along while holding onto furniture until they get that confidence and that strength in their leg muscles to be able to start walking. And once they master walking, then they start running. So you can't go from learning to lift your head up to running automatically. So we're always building on the skills that we have previously acquired and mastered. But when you have a child who has been trauma exposed, particularly a child who has experienced complex trauma, all of that energy, all of that effort that goes into development, that goes into learning and mastering new tasks, that energy is instead being put into survival and just getting through the moment, getting through today's trauma, getting through today's experiences and abuse, and just learning how to cope with an environment that is unstable, that is scary and just overwhelming, and it overwhelms a child's ability to cope. So this is where you start to see some stunted development. This is where you start to see children that are not able to keep up with their peers. And we actually see 7 domains of impairment in complex trauma cases, and you can see them listed right in front of you. And we'll speak about each one of these briefly. We see that there are impairments in attachment, in biology, in affect regulation, in dissociation, of course, in behavioral regulation, which is why so many of our kids come to us, in cognition, and in self-concept. When speaking about attachment, and please forgive me if I seem to go really quickly, there is quite a bit to cover, but if there are any questions, please feel free to send them in through the question function, and also you are able to access the slides for later review. When we speak about the effects on attachment, we see that in very young children especially, babies learn that when they are hungry, somebody feeds them. When they are hurt, somebody comforts them, somebody consoles them, somebody takes care of them. And they learn about safety, they learn about security. But when you have children who are trauma exposed, when you have children who are experiencing complex trauma, then those attachment patterns become very insecure. So they are not able to trust that their needs are going to be met. So there's a lot of uncertainty about their safety, a lot of uncertainty about their security, and the world just becomes a not very safe place for them. Things are not only uncertain, but also very unpredictable. And so this is where you're going to see those disrupted attachment patterns. This is where you're going to see that inability to form attachments, that inability to bond with a caregiver or to bond with anybody else. So you'll see that avoidance, you'll see that ambivalence, and you're going to see those disrupted boundaries also. So not only the children who are unable to attach, but also you will see children who are trying so hard to attach that they have no boundaries. And these are the children who will begin engaging in inappropriate relationships because they have not learned how to establish those boundaries. But more often than not, what you are going to see is a lot of suspiciousness, a lot of distrust. Because again, if I am a trauma exposed child, if I am experiencing complex trauma, then my experience in this case has been that the people that should take care of me do not take care of me. The people who are supposed to keep me safe do not keep me safe. So I, as a child, then will become very distrustful and very suspicious. And it, as a secondary effect to this, we're also going to see a diminished ability to regulate emotions and behavior. You're going to see the children that are not able to self-soothe. These are going to be your toddlers, your young children who are going to have a lot of these disruptive behaviors. It's also you're also going to see you see it in our last bullet that they are very quick to arouse and very slow, very difficult to calm. And it's also very difficult for these children to develop a capacity for empathy. So you're going to see this in maybe preschool age children and in young school age children where it's very difficult for them to attune to other children's emotional states. And so this is the child who's going to lash out, who is going to hit, and who's not going to understand the consequence of, oh, I'm hurting a child, I'm lashing out at a child, I'm going to hurt his feelings. We're also going to see effects of complex trauma on biology. You are going to see that neurobiological development is going to be modified by the experiences that the child is having. And oftentimes, a lot of adults believe that infants, especially, are really not affected by what's going on around them. We believe that because they are so young, because they are not verbal, because they do not have that ability to, form thoughts or to respond to what's going on. Their cognitive development isn't mature enough yet, that they are not impacted. But what we have found is that children, infants who have been exposed to violence, these infants, when brain scans have been done on infants exposed to violence and compared to the brain scans of infants not exposed to violence, we have seen that those exposed to violence are showing less gray matter in their brains. And this is something that is going to become evident as these children grow. And it's going to manifest itself in learning disabilities. These are going to be the children that are going to be diagnosed with a learning disability. These are the children that are going to have trouble staying on task, learning new skills. These are the children who may be diagnosed with ADHD or some similar disorder. And these are neurological effects that are the direct result of trauma exposure. So even in very, very young children that we are thinking are really not impacted because they don't have that cognitive awareness, they are still experiencing it. And so these littler ones, they are at greater risk for failing to develop the brain capacities necessary also for regulating emotions in response to stress. So I'm sure that several of you who are listening in have come across children who seem to overreact. And you're thinking, they're just making a really big deal out of something that's not such a big deal. Well, this is because their brain is not able to regulate those emotions. We also see biologically that continued trauma exposure is interfering with that integration of the left and right hemisphere brain functioning. And this makes it very difficult to access rational thought. I mentioned, I believe in the previous slide, children will engage in a behavior and not understand that there is a consequence to what they did. So that cause and effect, that reasoning ability is going to be delayed. And so they're going to react to that overwhelming emotion that may not, in a way that may not necessarily be appropriate. And they are going to react with extreme confusion, with extreme rage when they are stressed. And those feelings of helplessness and hopelessness also are going to be that much more overwhelming. And in terms of biology also, we do know that there are several medical issues that are exacerbated by stress. So conditions like asthma, skin disorders, autoimmune conditions, we know that those are exacerbated by stress. So these are going to be your sickly children. And of course, we do see increased somatization, but these children will actually get sick because of the stress that they are experiencing. In terms of affect regulation, we've spoken a little bit about this already, but again, they do have difficulty with regulating their own emotions. It's very difficult to describe what they are feeling. And most children, especially younger children, we know that they have a very rudimentary language when it comes to affect. So they can pretty much tell you happy, angry, sad, scared. But for children who have experienced that ongoing complex trauma, even identifying those very basic feelings, happy, angry, sad, scared, that becomes very difficult. So they're going to express it, but they're going to express it in a way that seems aggressive, that seems volatile. And it's going to, again, be very difficult to calm these children. And as these children get older, they're still struggling with that ability to self-regulate. So this is where we're going to see those higher rates of depression, higher rates of anxiety, and also higher rates of substance use and self-injury. Because they're not able to regulate, because they're not able to help themselves to feel better and to calm themselves. I'm sure that we've all had moments where we're so overwhelmed with something and we're so upset and we just, sometimes we lash out. Sometimes we may yell at somebody. We may say something that we later wish we could have taken back. We may throw something. We may slam a door. We may kick a wall or something. But that will quickly pass, and we're able to realize, okay, I need to calm down now. So let me engage in an activity that is going to calm me. This becomes really difficult in cases of complex trauma, so you will see more difficulty. excuse me, dissociation. I recall once having to testify in a case of an adolescent boy who had witnessed a murder. And even though the person who was murdered was somebody that was very, very close to him, it was a cousin who was more like a sibling, and the murder had occurred right in front of him. I mean, just a couple of feet in front of him. He couldn't recall details of the event. And this was something that came up in court when he had to testify and when I had to testify. And there were a lot of questions about how could he not have a memory of what he witnessed. And prosecutors were arguing that he must be lying. And I had to explain to them that it is possible to dissociate and to not be aware of what is happening and to not have a memory. So that amnesia, those alterations in states of consciousness, that does actually happen. So it is possible to experience something that is so scary and so overwhelming that our brain tries to protect us from the pain of that memory. So we will dissociate. I recall another case where a young girl was repeatedly sexually abused, and she could not recall details of the abuse itself, of the acts that were committed against her. But given a pencil and a piece of paper, she could draw in great detail this intricate wallpaper pattern, which is what she would focus on when she was being hurt. She dissociated and she just focused on this one thing. And so it does almost seem as if it's not real, as if it's happening to somebody else. In very extreme cases, and this would be a trauma case that is left untreated, then we can see some cases of DID, of dissociative identity disorder, but that would be a very extreme form. And we do know that left untreated childhood trauma exposure can be a precursor for physical and mental health disorders in adulthood. And okay, my slide was not advancing again. In terms of behavioral regulation, again, I often say, even though I'm known for doing trauma work, most of the children that are referred to me are referred because of behavioral issues. So you will see not only behavior that is under control, so the children that are experiencing behavioral problems, but you'll also see some behavior that is over controlled. So this is going to be the child that is trying so hard to be the perfect kid. Because if I am the perfect kid, if I do everything right, then I will not be noticed. And maybe I will not be hurt then. And that's almost a defense mechanism. And you're going to see these patterns as a way of adapting and coping with that overwhelming stress. A lot of children are also going to reenact the trauma, and the way that they're going to do this is by being aggressive, by engaging in overly sexualized behaviors. They are going to, again, attempt to self-injure or to engage in other risky behaviors, and this is just an attempt to attain some sort of mastery over their trauma reminders. So you are going to see a lot of externalizing behaviors, but you're also going to see a lot of internalized behaviors with complex trauma. You're also going to see a lot of changes in cognition. And so these are going to be, the children who are self-blaming. We're going to see also, in terms of cognition, we're also going to see not only the distorted thoughts, not only the unhealthy, the unhelpful, the inaccurate thoughts, but we're also going to start to see those learning disabilities, those difficulties with staying on task, with mastering new skills, with keeping their attention on the task that they are supposed to be completing. You're going to see this in school, and this is going to lead to greater dropout. This is going to lead to greater truancy, and that in turn is going to lead to lower grades, lower test scores. And you're going to see 3 times the normal dropout rate in children who have been exposed to complex trauma as opposed to those who have not. And you're also going to see a lot of those delays, and I mentioned this earlier, and this can be an effect of even children having been exposed to some type of violence. You're going to see it manifest itself later. So delays in expressive language, delays in receptive language, delays in being able to read and to comprehend and to reason abstractly. And the last domain that is impacted is, of course, self-concept. And I think a lot of this goes back to those difficulties with attachment and forming and maintaining those bonds. There's not only that unpredictability of the world and that view of the world as a dangerous place, but there's also this unpredictable sense of self. And for a lot of these children, there is that sense of separateness and this feeling that I am the only one who has ever gone through this. Nobody understands what I have been through. How could they if nobody else is experiencing what I have experienced? And so children start to feel very isolated, and this does affect their self-esteem. It affects their self-concept. You will see a lot of disturbances in body image as well. And of course, the distorted cognitions, the shame, the guilt, the self-blame, some of it which comes from them and some of it that they have internalized from what they've been told by perpetrators or even caregivers in many cases. So we've seen briefly the 7 domains that are affected by exposure to complex trauma. So let's look briefly now at how TF-CBT addresses all of these issues through its components. First of all, we know that when there is violence, when there is abuse, when there is self-injury, that is often ongoing. And so this is something that we always need to be checking in on. So if you all recall from our original TF-CBT trainings, we do not always implement the TF-CBT components in a certain order. We learn them in a certain order. We often refer during consultation to the practice components, but we take them out of order when we implement them. And that is based on the needs of the child that we are working with. And so even though, if you look at the practice acronym, even though the final component is the E, the enhancing safety, that is often the one that has to come first, because we need to establish that there is not only physical safety, but also emotional safety for the child. So in the very beginning, as we're even starting TF-CBT, we want to make sure that safety is being addressed, that safety planning is being done, again, not only for physical safety, but for emotional safety as well, and that we are already identifying who the support system for this child is. As we begin TF-CBT and we provide psychoeducation, we're not only educating them about all of the different traumas that they've experienced, but we're also starting to look at identifying what their triggers are. And there are so many triggers when you have complex trauma. But we also want to, and this is a combination of psychoeducation and safety as well, establishing for children, helping them to set healthy boundaries, learning about healthy sexuality. And I often say that my role really is not to provide sex ed, and that's not what I'm doing here. I'm just trying to teach them about what is a healthy relationship versus what is an unhealthy relationship, so that they are able to identify that certain behaviors that are being perpetrated against them, or that they maybe are perpetrating against others as a result of their victimization, are not healthy behaviors. And so we do want to, again, because attachment has been disrupted, we want to provide psychoeducation on boundaries. And we want to normalize that. We want to normalize their reactions and the fact that they are quick to arouse and they are slow to calm. That is something that we want to normalize and start to focus on. And of course, the other P in practice is the parenting. And oftentimes, parents are not able to or not available to support a child. If you recall, also in TF-CBT, we do not engage the offending caregiver. So we really want to take a systems approach and identify all of those adults who play a significant role in the child's life and who can be that support system for the child. So looking at complex trauma, there you see the TF-CBT components, our practice acronym again, and you also see the domains of impairment. So as we begin providing safety, we are impacting positively affect regulation. We are helping children to start learning to calm themselves as they start to feel safer, and also learning to express what they are experiencing and what they are feeling. We also, as we work on safety, we're starting to address behavioral regulation, because again, the safer and more secure that I feel as a child, then the less disruptive behavior the adults around me will start to see. As we start implementing psychoeducation, we are impacting biology, because we are starting to normalize that, okay, a lot of these biological reactions, these are normal. So let's talk about what is happening. Let's talk about how to address it. So psychoeducation is already starting to impact this. As we do parenting, then we are working on attachment. And even though attachment has been disrupted in infancy, we can still work on, and this is part of what we do in the parenting component, is we are working on establishing and strengthening relationships between caregivers and children. So we are impacting attachment, but we're also impacting behavioral regulation, because part of what we're going to address in parenting is also how to differentiate between a trauma-related behavior and just a kid being a kid, just a kid being a typical 8-year-old, just a kid being a typical rebellious adolescent. And parents also learning how to establish some boundaries and set some rules and set some consequences. And this is where children are also going to start learning about cause and effect. So this is now going to start to regulate behavior, but it's also going to help the child to regulate their self-concept. Parenting is going to go a long way towards the child starting to see themselves in a more positive light. So we're starting to see here how those early TF-CBT components are already starting to positively impact a lot of those domains which have been impaired. Through the relaxation component, of course, we are identifying previous coping strategies, what has been helpful, what has been unhelpful, because not all coping strategies are helpful. For example, a child who has been coping through substance use or coping through self-injury, those are not helpful strategies. So we're trying to identify what works, what doesn't, and even what works, is it a healthy technique? We are validating also that a lot of those unhelpful strategies, those were behaviors that they engaged in because they were trying to feel better. So they were doing the best that they could with what they knew. So we want to validate that for them while at the same time starting to identify more healthy, more helpful relaxation strategies. And one thing that we're starting to add is a lot of mindfulness activities, especially for dissociation symptoms. So, looking back at our connections, as we start incorporating the relaxation component, then we see that biology, again, is being impacted. Um, so all of those changes in the body, we talk about how stress can make us sick. And so children exposed to complex trauma are so overwhelmed with stress that they are seeing medical issues that are being exacerbated. As we learn to relax, then those symptoms will start to decrease. And we also see some more affect regulation. So if I am a child who is affectively dysregulated, as I learn to relax, as I learn to manage my stress, as I learn to cope better, then I'm better able to self-soothe, and I am better able also to regulate my emotions. And also, this is going to help, especially the mindfulness with the dissociation. And again, I'm keeping an eye on the time. I do want to be respectful of everybody's time. So we're going to go through this fairly quickly. In terms of the affect component of TF-CBT, that affective identification, again, and I think this is review for many of you, we are identifying the emotions that are useful. We're helping children to build a feelings vocabulary that many of them do not have, and to be able to identify when they are numbing themselves or they are dissociating. And it's not only about identifying the emotions, but it's also about rating them, because I can be upset about something today, and I'm upset, and so I seem a little bit bothered, I seem a little bit distracted, and that's fine. But I can also be so upset about something today that I am yelling at my staff here at work. And I tear out of the parking lot and I'm so distracted that I hit somebody in the parking lot. And then I start yelling at them and the police show up and I become volatile with the police. So that same anger, that same upset that I was feeling today can come in different strengths. So we also help children not only to identify what they feel, but how strongly they feel it. So am I upset at a 2, which just means that I'm a little irritable, or am I upset at a 10, which means that I'm going to go home and kick the dog? So we want them to be able to rate that so that they are able to regulate their emotion and bring those negative emotions, so the anger, the anxiety, bring that down to a more manageable level, but also increase the positive emotion. Negative affect states, they are temporary and they can be tolerated. And this is something that we want children to learn, is that I'm so angry today, my anger is at a 10, but this is going to pass. I just need the skills to learn to regulate that, combined with all of the other skills that I have been experiencing. And of course, for children, something that can be really scary and overwhelming is that they have multiple feelings all at the same time. And a lot of those feelings may be conflicting. So, for example, you may have a child who is sad because parents are separated and one parent is no longer in the picture and they really miss that person. But at the same time, they're really happy that that person is gone because that means that the abuse is no longer occurring because the perpetrator is out of the house. So that can get a little confusing. How can I be happy and sad at the same time? That's really weird, and so that there must be something wrong with me. So we want to normalize that for children as well, and teach them how to communicate their emotion, because as they do that, that is one of the things that is going to help alleviate the intensity of what they are feeling, and this is how they're going to be able to ask for the help and the support that they need. So we go back to our relationship picture here. We see that affect modulation, that component, of course, is going to impact affect regulation. And it is also going to impact dissociation, because as children learn to identify and endorse what they are feeling and learn to manage it, then you will see that that avoidance, that need to dissociate, will start to decrease because those feelings are not so overwhelming anymore. The C component, the cognitive coping. A lot of children have some deeply ingrained, distorted cognitions that have helped them to survive. So things like I cannot trust anyone. Some of the ones we mentioned earlier, that the people who are supposed to keep me safe do not keep me safe. The people who are supposed to love me are the ones that hurt me. Before, I think our natural instinct as therapists, as helpers, is that we want to immediately tell them, no, 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 it's not your fault. No, 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 the world is not a horrible place. No, there are people that you can trust. There are people that love you. But us feeding it to the child is not going to have the same impact as if they are able to elicit that themselves. So before we can do that, though, we need to validate what they are experiencing, what they are thinking. So all of those distorted cognitions, all of those unhealthy, unhelpful, inaccurate thoughts, we need to validate them. And yeah, you know what? Considering what you've been through, it's normal to feel like or to think that you cannot trust anyone. It's normal to think that nobody loves you. Let's talk about that now. And this is where we start doing, our progressive logical questioning. This is where we start to do the Socratic questioning, and we start to challenge all of those distorted behaviors. And this is where you're going to start to see that a lot of those thoughts that come up during stressful situations are actually inaccurate. And those inaccurate thoughts are the ones that intensify all of those negative emotions. And those are the ones that are leading children to engage in behaviors that are not very healthy, that are undesirable, and that are problematic. So this is where our cognitive triangle that I love to use so much is going to come in. But before we challenge, we need to validate for kids. So we see here that the cognitive coping component is going to impact, of course, cognition, because we're going to teach children how to replace all of those distorted, unhealthy, unhelpful, inaccurate thoughts. And this, in turn, is going to impact their self-concept, because this is where we're going to see reductions in the shame, in the guilt, in the self-blame. Our biggest component in TF-CBT, and probably my favorite component, is, of course, the trauma narrative. So that telling of their story, that making meaning of how they have impacted and what this means for them. We will see, of course, that, for early memories, events that happened when they were nonverbal, there may be less detail. And some of the detail that does make its way into a trauma narrative may not necessarily be things that they remember, but they may be really reacting more to what they have been told. So children who've been told that when you were a little kid, your mom did this. When you were a little kid, your dad did. When you were a little kid, you were in an accident. When you were a little kid. So this is what they are responding to. Not necessarily the memory of what happened, but everything that they have learned about it. And trauma narratives, when you have complex trauma, can seem a little disorganized because where do I start? If I'm a child who has experienced 4, 5, 6 different trauma types, and these have all been ongoing, what am I supposed to talk about? There's just been so much going on. So you may see that it may seem disorganized. It may not be chronological. Not everything is going to make its way in there. But what is most important in complex trauma cases is making meaning of what happened. That and what we're trying to do with the trauma narrative is we're trying to desensitize our kids to all of those trauma reminders. But what's more important here really is helping them to make meaning of this. And so if the trauma narrative seems disorganized, then it does help to organize the narratives by themes. So instead of addressing the physical abuse and the sexual abuse and the domestic violence and the bullying and the next trauma and the next trauma and the next, looking at themes. What is that overarching underlying theme in my life? So if I think like a trauma exposed child, maybe the theme is that I have never felt safe. Maybe the theme is that I cannot trust anybody. So if my theme is I cannot trust anybody because everybody that I've ever trusted has hurt me, has abused me, either physically or sexually, or has hurt the people that I love, how does that affect me? How has that affected me as I've grown? How is it affecting me now? And how does that affect my future? So that's the meaning making. So rather than doing what we used to do when I started doing TF-CBT over a dozen years ago and focusing on what is the most distressing trauma for you, looking at those underlying themes. So our trauma narrative is going to impact affect regulation because as children learn to make meaning of what happened, then they're better able to regulate how they feel about the event and how they feel about themselves. It's also going to start to positively impact their cognition because the child, through the processing, the developing and the processing of the trauma narrative, starts to realize that hey, I wasn't to blame for what happened. Hey, I don't feel as guilty anymore. Hey, I did not cause this event to occur. Hey, this wasn't a punishment for something that I did. And of course, as those thoughts change, then self-concept also changes because if I didn't cause it, if I wasn't to blame, if I didn't play a role in this, then maybe I'm not this horrible kid that I've thought all along that I was. The in vivo mastery, of course, we know this goes along with the relaxation and starting to identify what all of those triggers are. The in vivo mastery is going on throughout the course of TF-CBT, and it's an attempt at desensitizing the child to those associations. And not so much desensitizing them to the situation itself, because what is hurting the child right now isn't the trauma itself. It's the memory of the traumatic event. So we are trying to desensitize them to those memories, to those triggers, to all of those trauma reminders. And as we do that, and we go back, and this is starting to look a little convoluted now, we start to see that, again, affect. Because as I gain mastery over all of those things that dysregulate me, then I become less affectively dysregulated. Of course, assuming and hoping that we have a supportive and engaged caregiver, then we will have our conjoint sessions. And during our conjoint sessions, us as therapists, we're going to, of course, assess, before we even do this, assess the caregiver's ability to respond in a supportive manner. I don't ever want to have to stop a conjoint session because I have to deal with a caregiver who's interrupting and saying, it didn't happen that way. I told you my kid lies. Let me tell you what really happened. No, that's not the truth. So I need to know that I'm working with a caregiver that is supportive, that is able to regulate their own responses. Because also sometimes it's not just about caregivers being blaming, it's about caregivers being so overwhelmed with what has happened to their child that they are unable to cope themselves. It doesn't have to be the primary caregiver. Any significant and supportive individual can play that caregiver role and can be part of the conjoint sessions. So we always want to look for those supports. And if you will remember from our training and if you will remember from our consultation calls, we can do TF-CBT even if there is no caregiver available. So it is possible that conjoint sessions may not happen if we do not have caregiver participation. But we do want to make every effort to engage, to identify and engage supportive caregivers. And this is also the purpose of our parent component of our parent sessions, is being able to prepare them, give them the skills so that they are able to be supportive and prepare them to take part in conjoined sessions and to eventually hear a narrative. So assuming and hoping that we have that supportive caregiver or caregivers, and we are able to have conjoint sessions, then we are going to see that conjoint sessions are going to impact attachment, because now that child will know that there is somebody safe, that there is somebody that cares, that there is somebody that they can trust, and that not everybody is going to hurt them. So we are really looking through our parenting and our conjoint sessions at really strengthening that relationship between the child and the caregiver or other supportive adult. But we are also seeing that through that, we're going to see that increased or that improved self-concept. Because again, if I am that trauma-exposed child and I start to see that there are people who care about me, there are people who will keep me safe, there are people that I can trust, then maybe I am worthy. Maybe I am worthy of that love and that care and that attention. And then enhancing safety part 2, even though we often in complex trauma cases, or almost always in complex trauma cases, begin with the safety component, we also want to end with safety. And we, of course, are doing safety throughout the course of TF-CBT. But in the beginning, it's about establishing that there is safety and that the child is stable enough that we're able to work with them. But at the end of treatment, we want to talk about preventing re-victimization. And we want to be really careful because prevention doesn't lie with the child. Prevention lies with the perpetrator. But so we never want to come across as if we're saying, well, if only you did this, you'd be safe. But just teaching them that if they ever find themselves in a potentially unsafe situation, what are some things that they can do to reduce the impact or reduce the likelihood that they will be hurt again. So, and there are specific things that we want to look at. For example, trafficking, internet and social media. This is such a big one, and I could probably speak for another couple of hours about that. But we want to teach children about being safe on the internet, not just social media, but even gaming. Through gaming consoles, children can be targeted and groomed by perpetrators, that lure, back to grooming, that lure of gifts, that lure of shelter and safety and security and drugs for those that are already substance using. And also part of the enhancing safety in the end is going to be about goal setting. So we go back to the meaning making. How have they been impacted? And what do they want for their future? And the final thing is all about ending treatment and recognizing that for a lot of children, this is going to be the first healthy goodbye that they've had. And so I have made it a point, as I know that we are getting ready to wrap up treatment, to just check in with children and just let them know that they have done such a great job. And this ties into that bullet about termination equaling achievement. I compare ending treatment to school. You know, you go to school for all these weeks, all these months, and when you learn everything that you're supposed to learn in fourth grade, then you end fourth grade and you move on to fifth grade. And when you learn everything that you're supposed to learn in fifth grade, then you end fifth grade and you go to sixth grade. And that's what counseling is like. So they have learned everything that they were supposed to learn in counseling, so they're going to graduate. And graduation, remember, think about school. If you all think back to when we were in school, didn't we all think about 4 more weeks of school left? 3 more weeks of school left. 2 more weeks of school left. And even now as adults, don't we sometimes count down to, hey, 2 more weeks and I get to go on vacation. 1 more week and I get to go on vacation. 2 more days and I get to go on vacation. I do that with kids. And I just let them know that, hey, in 4 more meetings, you're going to graduate. In 3 more meetings, you're going to graduate. In 2 more meetings, you're going to graduate. And the reason that we want to do this is because we don't want to trigger any additional feelings of loss or abandonment. And for a lot of children, that is how they may portray this, as you don't want to see me anymore. You're just one more person that doesn't love me, that doesn't want me, that doesn't want to be around me, that doesn't want to spend time with me. So we want to gradually ease them into that termination. And transitional objects may also be really helpful, something that they can take with them, and photos together. I've had a lot of children who want to take a picture with me during graduation, and that's fine. And that genuine disclosure also can really help. And I do let my children know that, I've really enjoyed working with you, and, I'm going to be sorry when you're no longer here, but I'm so excited that you're graduating. So, I'm trying to be respectful of everybody's time. I have been watching the question box, and I've only seen one question, which is in regards to whether or not a certificate of completion will be provided and whether CEUs will be provided. And that's something that our moderator can speak to.
Yes, so for those, we do not offer any kind of certificates of completion or CEUs for the webinars. These are just for your enjoyment to learn some good information. We actually do have a question, Dr. Rivera, that says, would you consider symptoms of schizophrenia, for example, hearing voices, as a form of dissociation? And that came through towards the beginning of your presentation.
Okay, and I did not see that one, so thank you for reading that one out to me. I see that actually as a symptom of re-experiencing, because I've actually seen quite a few children who are suspected, and I see this in older children who are suspected of being diagnosed with schizophrenia because they are having hallucinations, auditory or visual hallucinations. And as we work with them, what we come to find is that they are actually re-experiencing. So it may be a sign of dissociation, but I would more likely relate it to a symptom of re-experiencing, which is a hallmark of PTSD.
Great, thank you for that explanation.
And that actually was perfect timing because you brought us right up to the end of our time. We are right at 12 o'clock. I do appreciate all of you spending your hour before lunch with me. And even though I have just learned that you are not receiving any kind of CEUs, I do appreciate that you all were on, and I hope that you have found this useful. For some of you, maybe a refresher, and for some of you, maybe you hopefully learned something new today. So thank you all for being with us this afternoon. Have a good day.
Thank you.